Coming everyone. I'm Janet King. I'm from NHS England and I'm the Regional Head of Intelligence for the North of England, which I have to say, after a long career in the NHS, is both the best job title I've acquired so far, but also quite hard to live up to. And as you can see, I'm here to talk about information governance. It's something that I think is a phenomenally important aspect of all of the things we've talked about today. We've heard some fantastic and really inspiring stuff this morning, very visionary information about the technical architecture. We've heard from Liz, who was, I thought, very, very articulate about the patient perception and the patient experience. And one of the things I want to talk about is the governance framework that surrounds and supports that, or possibly doesn't. So I called the presentation Burden or Benefit, because my perception is that information governance is too often seen as a barrier or a blocker, and you very rarely hear of it described as a beneficial safeguard for the system. So I want to talk through a few slides about what I think some of the challenges are, and then I want to spend the rest of the session, and we've got until 2:30, to hear your views and have a bit of a debate and a discussion about how we might take that forward. Oops. There we go. So first of all, some of the challenges that we face across the ecosystem. I think one of the first ones, and I should have said at the beginning, one of my other roles is to be the regional lead for care.data, which got a bit of a name check this morning. Luckily there's no booing at the moment, but it's happened before. And when I've been going out doing engagement events with professionals, healthcare professionals, and with the public, one of the first issues we come across is a confusion about the difference between data sharing for direct care and data sharing for other purposes, and care.data falls particularly into that other purposes camp. The second challenge, I think, is around establishing a legal basis for fair processing. We know that we have a lot of hoops to jump through sometimes around the legislation, but when we address those and understand the legal framework, and we establish the legal basis for data processing, then a lot of other issues fall into place. And fair processing, this is something that I'm personally very keen on and very invested in. Under the Data Protection Act, we have the obligation, where we are data controllers, to undertake fair processing. And fair processing, in a nutshell, means ensuring that data subjects are clear about the uses of their information and clear about their rights to control that information. Now, one of the things that care.data has taught us very clearly is that there is a great gulf between the attitudes towards fair processing in primary care and in secondary care. And that's something that I think is going to be fundamental to integrated data sharing. And leading on from that is identity management. When we talk about fair processing and we talk about patients giving consent to data being shared, we've got to be very clear, first of all, about who's giving that consent, but also about the identity of individuals who can then access that data. So for me, that's a bit of a two-pronged approach. It's both ensuring that the right person gives their consent to data sharing, but also that the right person accesses that shared data. Something that's become very clear from talking to organisations and individuals around the North is the lack of good quality, easily understandable and easily accessible guidance around IG. And that's something that I think we really do need to address. And finally, my hobby horse is around consent. My personal feeling is that the NHS for too long has relied on implied consent, and that for all the issues that we have with care.data, it has a great strength and a power that it's opened up conversations around consent, which is just conversations that we've needed to have for a long time, and now we're having them. And sometimes they're difficult conversations. I think another one of the challenges is around the system complexity, and this is something that I think was very clear from the speakers this morning who were attempting to distill the complexity of the organisations, the data types, the systems, down into something that fits on one slide. And I think we could all see that, you know, obviously a huge amount of work had gone into that, right up until we got to Declan's slide, where we had to go into the fourth dimension of time to see the data flowing and to make that architecture diagram come to life. One of the issues that's become very apparent is around how we manage the complexities and the understanding and take patients with us on that journey between local data sharing, and we've heard examples of this morning, and national data sharing. I think it's very apparent, and I think Lizzie's talk this morning really brought this out, that where we are least good at managing information, managing patient experience, and managing joined up effective care is at transitions. And that can be as simple as transitions between different departments within an organisation, but it's even more apparent when we're talking about information flowing between organisations. And then when you add into that, when you add into the local clinical record sharing, national systems such as the summary care record, patient online, e-referrals, GP to GP, electronic prescribing, and the infamous care.data, you've got an incredibly complex environment, and we've all got a role in helping patients, other professionals sometimes, to navigate through that. Then I wanted to talk about identity and linkage, because as well as having lead for care.data in the region, I'm also on the NHS number programme board. Now, we have a Secretary of State commitment, which is that 75% of organisations will be using the NHS number as the primary identifier. And on paper, we've achieved that. 75% of organisations assessed across the country, across England, have confirmed that they use the NHS number as the primary identifier in clinical correspondence. When you dig a little bit deeper, the picture's a little bit more patchy. They may indeed have a data flow that uses the NHS number. My personal suspicion is that actually that's a lot of organisations that have a template that drops the NHS number onto a discharge letter, and therefore they feel that they meet that requirement and that commitment. So we've got a national identifier. How are we using it? Does it meet all of our needs? And what do we do to fill the gaps? How do we use local and non-NHS identifiers? It comes back to the issue about identity management. I think there's a big piece of work to be done there. And I talked just before about identity supporting consent. Again, when we've talked about care.data and the implications of that and how that will work in practice, we've talked about GP practices managing the consent model. So if a patient wishes to opt out, they contact their GP practice and their opt-out is recorded. Now, at the moment, there's no mandate or no standard as to how that practice verifies that the person who rings up or fills in a form is the person whose record they're updating. Gets even more complicated when you start to talk about transition from child to adult services. We've got GPs who are very keen on working through how we term this alongside Gillick competence, and then at the other end of life, as people move from being independent to perhaps being cared for or having an advocate or someone with power of attorney, again, how do we transition that consent around data sharing, and how do we transfer that consent? Obviously, showing my background, having worked in provider organisations, when we're working in an integrated way and we are integrating records across organisations, we're going to have to come to terms with how we manage record destruction. Who's responsible for that? If we have a patient-held record, what happens to that record when the patient is no longer capable of holding it? How do organisations fulfil their legal obligations to manage that data, to hold the minimum data that is required, to hold it for the appropriate length of time, and then to destroy it safely? And how do we manage duplicate identities? When I used to work in a specialist orthopaedic hospital, we came across a case of two twin brothers. One brother died and the other brother assumed his brother's identity, including using his NHS number, taking his name, and obviously had access to all the kinds of information that made it very easy for him to pass himself off as his brother. And it was only actually discovered what had happened when he came into hospital for an operation, because there was some medically relevant difference between the two brothers. So how do we manage both that kind of approach, but also how do we manage duplicate identities in the system? So I said I wanted to talk about fair processing and consent, because these are things that I think are absolutely fundamental. If we take an ecosystem-wide view of data sharing, and to be honest, I can't even conceive of a future in which we're not talking about holistic data sharing. I really, really don't think we can continue to hold records in silos. How are we going to develop consistent messaging and query handling? And that's both from a technical perspective, which I think you've heard this morning. There's a lot of really good work that's going on there, that's making progress. But also, there's a patient perspective. How do all the organisations who have a hand in someone's care give a consistent message to them about how their data is used? How do we actually deliver fair processing? And where do we signpost people when they've got queries? How do we handle that? Again, I mentioned explicit and implied consent, and a personal view again is that the NHS previously has relied very heavily on implied consent, and implied consent on the basis that data is being used for direct care. And as I said before, I think care.data is starting to unpick some of those assumptions and help us to explore that conversation. I think the ideal would be a model that works entirely on explicit consent, but for that you need informed staff who can inform patients, and you need that broader conversation. You need a layer in whichever model you look at, whichever technical architecture, that manages consent on an ongoing basis and recognises that people's consent status can change. I've talked about competence and capacity and carers and advocates. And again, one of the things that's come out very clearly from the work we've done with care.data is that people actually take quite a subtle and nuanced view around consent. The majority of people will consent to data sharing to support their direct care, certainly their direct health care. It's sometimes, I think, a little bit of a different conversation around bringing in some social care into that. We found that people, on the whole, felt that it was appropriate for the NHS to have access to management data for planning purposes, for service developments. And then we got into the area of research and development, and that's where views became quite polarised. We have a large group of people who say no commercial company should have access to that data, but are actually saying they're quite happy for a university to use the information for research. Well, unfortunately, in this day and age, if you scratch a university, you will find a commercial interest. And so having some of those conversations with people who take a very black and white view of something that's actually quite subtle and delicately shaded can be quite difficult. So it's hard enough to do that, have that conversation from the perspective of an individual organisation. I'm really interested to hear views from the room about how we have that conversation across an ecosystem, which comes back to the point about consistent messaging. A little bit about the data, the legal framework here. Obviously, we've got the Data Protection Act, we've got the Health and Social Care Act, and the Care Act itself. Now, the Health and Social Care Act, as the later legislation, takes primacy over most of the Data Protection Act, but what it doesn't overtake is the responsibility around fair processing. And these are some really difficult conversations we've had, particularly with GPs as data controllers, in helping them to understand that. With the Health and Social Care Act came the legal power for NHS England to issue directions to the Health and Social Care Information Centre to collect data, of which care.data was the first major application of that power. And under the Care Act, we've got the creation of registries of information, and I was having a conversation over lunch about how we actually manage that. How do we support the collection of clinically relevant data that's not involved in direct care? I wanted to touch a little bit on some of the myths that I've heard through a number of engagement events around information governance, which comes back to the burden or benefit question, I think. The first being that information governance prevents data sharing. That's quite a common view, and one that's quite often put forward as a reason for avoiding some of the more advanced data sharing projects. As I touched on earlier, there is definitely a perception that NHS data collection is all covered by implied consent, and it absolutely isn't. From primary care, there are concerns that the Health and Social Care Act can impact on safeguarding by preventing data sharing when it's required, when it's clinically relevant, or socially relevant in that case. We've seen in the press concerns that care.data will allow the police to trawl medical records. Again, not true, but how did that particular perception get out into the public? How is that myth being promulgated? I'm sure you've seen the debates about Health and Social Care Information Centre selling information to commercial companies. And also, we've struggled with the concept of whether pseudonymised data can support all secondary uses of data. And a colleague from the National Strategic Information Governance team did point out, with a rather pained expression in one meeting, that legally there is no pseudonymised data. Is either identifiable or it's not. So we've got ourselves slightly tied up in knots over that, I think. So those are some of the myths that I think are abound at the moment, and some of the things that I've come across on my travels. I mentioned guidance earlier, and I just thought I'd take the opportunity, just in case anyone's not come across it, to mention the new Information Governance Alliance. Its website is hosted by HSCIC, but it's although it has input from HSCIC, DH and NHS England, it sits apart from all three of those organisations, and it aims to provide a single source of information and guidance, which I think will be greatly needed. It'll provide support for those staff who handle personal information, and it'll provide expert advice and a knowledge sharing network. And I think that's really important, because one of the things that we've struggled with is a lack of trained information governance staff. If information governance is going to underpin moving to an integrated care environment and integrated data sharing, then I would pose the challenge: how are we bringing on a cadre of information governance enabled staff? They might not be IG specialists, although we need those as well. But how are we actually giving frontline staff the confidence to handle records securely and in line with the law? So the last bit that I wanted to talk about was really to open up a bit of a debate about what sort of solutions are needed, what sort of solutions are out there. This kind of event is brilliant for this, because we've got a fantastically engaged and informed group of people in the room. So I thought we could maybe talk about what consent models are in place, whether, my own pet theory here, there should be a national register of data sharing, because we've talked outside of the meetings, in the informal sessions, we've talked about how do patients know where to go to find out how their data might be shared. So if I come a cropper in Chester, how easy is it for me to find out what data is shared there? Compared with if I went to see a GP in Leeds, it would probably be easier for me to find out there how my data might be shared. I touched on research registers and how we support those and how we bring those into the fold. And I wanted to just talk about some principles here. Openness and transparency. Of all the things, all the culture change that we're seeing through the NHS at the moment, I think this one has the potential to be one of the most powerful. It's cracking open the NHS and trying to break down some of those old hierarchies, particularly a sort of paternalistic approach to the delivery of healthcare, where the clinician knows best and the patient will receive those services and that information that it is deemed suitable to share with them. Engaged and empowered data subjects. I've quite often listened to a GP in Manchester, Dr. Amir Hannan, speak about empowered and activated patients, how giving patients access to their records engages them in their care and gives them the information, much as Liz was talking this morning, the information that's pertinent to them, that might change some of their behaviours, it might help some of their conversations with other clinicians. And finally, about making the transition safer, making it easier, more effective and more holistic to transfer between organisations, for your data to flow within one organisation so your test results end up in the right place at the right time. Make it easier and safer to transition from children's services to adult services, or at the other end of the spectrum, transition into end-of-life care or sharing carers' data. Oops. So that was all I wanted to talk at you about. We've got about 10 minutes left now, and I'd really like to hear your views and maybe open up the debate about how we need to address information governance to deliver the vision that we've talked about this morning of holistic and seamless care.